PCOS manifests itself as hyperandrogenism. Simply stated, this means high levels of androgens such as testosterone. This expresses itself as excessive hair growth in places that hair would not normally grow in women. Scalp hair loss is also common, as well as acne and obesity, or sometimes a combination of these. Women might also notice infrequent, irregular, or even absent menstrual periods. While polycystic ovary syndrome has long been recognized as a reproductive disorder, it's now also well established as a metabolic condition associated with long-term health risks, hyperinsulinemia, metabolic syndrome, and type 2 diabetes and cardiovascular disease. Additionally, adverse mental health outcomes and a reduced quality of life have also been reported. The American Society for Reproductive Medicine, or ASRM, concluded that PCOS should be defined by the presence of 2 out of the following 3 criteria. First, oligo-ovulation, meaning infrequent or irregular ovulation, resulting in longer than normal menstrual cycles, or anovulation, where the ovaries do not release an egg, which can also lead to irregular or heavy menstrual bleeding. Second, clinical and/or biochemical signs of hyperandrogenism, and third, polycystic ovaries. Polycystic ovaries are defined using transvaginal ultrasound as the presence of 8 to 12 or more follicles in each ovary, measuring 2 to 9 millimeters in diameter, and/or increased ovarian volume greater than 10 milliliters. In healthy women, the wave theory holds that 2 or more cohorts of 4 to 14 small follicles, each equal to or less than 4 to 5 millimeters in size, are recruited during the menstrual cycle, and that one dominant follicle emerges in the final wave. The leading follicle can be distinguished from the others by its size and the high mitotic index of the ovarian granulosa cells, which in simple terms just means the rate of cell division. Only the leading follicle has detectable levels of follicle-stimulating hormone, or FSH, in the follicular fluid. The leading follicle also contains significant levels of the estrogen, estradiol. Selection of the dominant follicle doesn't always guarantee progression to ovulation, but ovulation usually does occur. Polycystic Ovary Syndrome, or PCOS, is actually a misnomer. The disorder isn't primarily a problem with the ovaries, but rather, it's considered a neuroendocrine disorder. Neuroendocrine is just defined as the interaction between the nervous system and the endocrine system. The female reproductive cycle, which is usually called the menstrual cycle, is controlled by a neuroendocrine cascade involving the hypothalamus, the pituitary gland, and the ovaries, what is called the hypothalamus-pituitary-ovarian axis, or HPO axis. There's a neuronal clock located in the hypothalamus that releases intermittent gonadotropin-releasing hormone, or GnRH, and this hormone induces the release of the gonadotropins from the pituitary. These gonadotropins, specifically luteinizing hormone LH and follicle-stimulating hormone FSH, stimulate the production of the sex hormones estrogen and progesterone in the ovaries. FSH and LH are responsible for the growth and maturation of the egg-containing ovarian follicle through the timed production of estrogen, specifically estradiol and progesterone by the ovary. This is what is called the ovarian cycle. Estrogen and progesterone also promote cyclic changes in the endometrium, the lining of the uterus, to ensure the endometrium is prepared for the implantation of an embryo. The neuronal clock, which is made up of GnRH-containing neurons and is located in the hypothalamus of the brain, fires at regular hourly intervals. This results in the intermittent release of gonadotropin-releasing hormone, or GnRH. The GnRH is then transported to the anterior part of the pituitary gland via the hypophyseal portal system. Once there, GnRH stimulates the cells of the anterior pituitary gland, which in turn releases 2 hormones, LH and FSH. These 2 gonadotropin hormones, also called gonadotropic hormones, follicle-stimulating hormone FSH and luteinizing hormone LH, act on the ovaries. Follicle-stimulating hormone, or FSH, stimulates the development of ovarian follicles and the production of estrogen by its follicular cells. Luteinizing hormone, or LH, is the trigger for ovulation, which is the release of an egg or oocyte from the follicle. LH also stimulates the follicular cells and the corpus luteum, a glandular structure that develops from the collapsed walls of the ovarian follicle after the ovum. Egg has been discharged. The corpus luteum produces progesterone and estradiol. These hormones are necessary to maintain pregnancy, should it occur. Alteration of the hypothalamic pituitary ovarian axis, or HPO axis, is the major dysfunction observed in PCOS. This syndrome is driven because of the increase in the pulse frequency of the gonadotropin-releasing hormone, GnRH, from the hypothalamus. The increased pulse frequency of GnRH favors the synthesis and secretion of luteinizing hormone, or LH, instead of follicle-stimulating hormone, or FSH, by the pituitary gland. An elevation in serum levels of LH results in a high LH to FSH ratio, higher than 2:1, and promotes androgen production in the ovarian theca cells. Increased GnRH pulse generation in the hypothalamus leads to an increase in LH pulse frequency, amplitude, and also 24-hour mean serum concentrations. Increased luteinizing hormone secretion, together with enhanced ovarian theca cell responsiveness, drives the production of the excess androgen in PCOS. Additionally, increased androgen production may inhibit the sex steroid estradiol and progesterone negative feedback on hypothalamic gonadotropin-releasing hormone, GnRH, pulse generation. This results in the rapid LH pulse frequency seen in women with PCOS. Increased androgens are also associated with android obesity, visceral fat deposition, and dyslipidemia, which means abnormal levels of lipids in the blood. All of these factors may contribute to insulin resistance and compensatory hyperinsulinemia. Hyperandrogenemia, obesity, and hyperinsulinemia decrease sex hormone-binding globulin, or SHBG, and increase free bioactive androgens, further driving the disorder. Currently, PCOS is treated symptomatically with oral contraceptives and anti-androgens and insulin sensitizers. In women who are not trying to conceive, combined contraceptive pills are considered the first-line treatments for both menstrual irregularity and hyperandrogenism. The estrogen component increases sex hormone-binding globulin, which then reduces androgenic free testosterone and helps improve hyperandrogenism. Because this stimulatory effect on hepatic production of proteins leads to hypercoagulability, ethinylestradiol-based contraceptive pills containing the lowest effective dose of estrogen, for example 20 to 30 micrograms of ethinylestradiol, are recommended. Currently, available anti-androgen agents work by blocking androgen receptors. Examples of these agents: cyproterone acetate, spironolactone, and flutamide. An alternate approach, too, to reduce the production of androgens, with agents such as finasteride and dutasteride. Metformin, on the other hand, modulates hepatic insulin sensitivity and glucose production. And more recently, metformin has also been shown to mediate its antiglycemic effects by acting on the gastrointestinal tract and the gut microbiome. Metformin is used to manage weight and metabolic outcomes in adult women with polycystic ovary syndrome who have a body mass index greater than 25. Plus, metformin may also improve ovulation and live birth rates. An improved understanding of the pathogenesis of PCOS will result in the development of new treatments and better patient outcomes. Recent studies have really advanced our understanding of these pathophysiological processes. Neuroendocrine dysregulation leads to abnormally high-frequency pulsatile secretion of gonadotropin-releasing hormone, GnRH, and hypothalamic kisspeptin, neurokinin B, and dynorphin A neurons. These so-called KNDY neurons are integral regulators of GnRH pulsatility. Although increased production of ovarian and adrenal androgens contributes to hyperandrogenism, peripherally generated 11 oxygenated androgens are emerging as important predictors of metabolic risk. Together with advances in our understanding of adipocyte or fat-storing cell biology, insulin resistance, the gut microbiome, and insights from genome-wide association studies, these studies have improved our understanding of the pathogenesis of this disease. New treatments based on these observations are now in various stages of preclinical or clinical development. One example of a new approach is the inhibition of the neurokinin-3 receptor, which is believed to cause a tempered inhibition of gonadotropin-releasing hormone, or GnRH, pulsatility without excessive reduction because of the presence of compensatory pathways. A second approach takes advantage of the fact that when dynorphin binds to kappa opioid receptors, release of kisspeptin onto gonadotropin-releasing hormone neurons is inhibited. Thus, selective kappa receptor agonists with a central action might reduce GnRH pulsatility. Additionally, kisspeptin receptor antagonists have also been suggested as therapeutic agents in PCOS based on their potential to normalize hypersecretion of luteinizing hormone or LH, restore folliculogenesis, which is the process by which a fertilizable egg is developed, and ovulation can proceed. These agents are also projected to improve ovarian hyperandrogenism. Lastly, epigenetic factors have garnered considerable attention in the pathogenesis of PCOS. Heritable PCOS appear to be the result of changes in the content of DNA methylation, histone acetylation, and non-coding RNAs have been shown to be present in various tissues of women with this disease. Epigenetic changes are chemical modifications to DNA that regulate whether genes are turned on or off. DNA methylation is changed in the peripheral and umbilical cord blood, as well as in ovarian and adipose or fat tissue of women with PCOS, suggesting the involvement of this epigenetic modification in the pathogenesis of PCOS. Perhaps these defects in DNA methylation promote the deregulation of genes involved in inflammation, hormone synthesis and signaling, and glucose and lipid metabolism. Research on the role of DNA methylation in the pathogenesis of PCOS is just beginning, and several issues still await investigation.